Good morning, everyone, and welcome to the WellMed Charitable Foundation Caregiver Teleconnection Series. Today, we're fortunate enough to hear from an expert how to decide the difference between what's best for a person with dementia. Is it home health, palliative care, or hospice? And I just want to introduce Candace Ramos. We're so lucky to have you. Thank you so much for joining us, Candace. Tell us a little bit about yourself and your background, and then just go ahead with your presentation.
Thank you so much, Evelyn, and thank you so much, everyone, for being on today. Like Evelyn said, I'm Candace Ramos, and I'm a Senior Director of Market Development at VITAS Healthcare. We are one of the nation's largest hospice care companies, covering many different states in the United States. I have worked at VITAS for 8 years in many different capacities. But aside from my work at VITAS and getting the opportunity to work with so many different caregivers and patients that are facing the illness of Alzheimer's or dementia, I am a granddaughter. My grandmother had and passed away last year after a fall, and she had dementia. I'm a daughter of a father who had a mom with dementia. And so I have been on this journey with many of you, and I use this as an opportunity to share a personal story. That's why it's so important for me to share these differences, because my family went through an experience. And so I'm going to share a little of that experience with you today, not just as the representative from VITAS, but as someone that has had a family member in the same situation that you are, or that someone that you're caring for is in, even if you're a medical provider. So thank you for being here. The objective today is to provide information about different levels of care provided at home, to include palliative care, hospice care, and home health care for Alzheimer's and dementia patients. So I like to start with Mima's story. She was a 91-year-old with 8 children. And in October of 2022, she had 4 daughters providing 24/7 in-home care on a rotation schedule. Her daughters were all retired, which I know not everyone is able to be in that scenario, but she was blessed with that. Her wish was to be at home, and so they wanted to make that happen. They originally had started visiting her on rotating weekends, and then as her age and her ability to do her activities of daily living on her own continued to progress, they started to have to get to the point where they needed someone to be with her 24/7. That's something that she never wanted, but again, in October of 2022, she didn't even know that someone was staying with her 24/7. In October, after about 2 years of, that continual, we did weekends, and then we did couple days on and a couple days by herself, and then we transitioned to 24 hours a day. All 4 of the daughters started to experience personal life events, and they needed additional family to stay with mom. So one of the daughters, her husband was diagnosed with cancer. One of the daughters, her husband, was going through a hip replacement. So, different things come up. Life doesn't stop because you're a caregiver, and life still happens. So the granddaughter, agreed to assist and help with staying with Mima from a Sunday through a Thursday. Now, that weekend when we transitioned for the granddaughter to stay, multiple family members had visited on Saturday and Sunday, prior to the granddaughter staying with Mima alone. After all the visitors had left, Mima did not sleep for 20 hours straight after all the visitors had left. So for 24 hours after those visitors had gone, she'd stayed awake all night long. And you can believe that the granddaughter also stayed awake, or was awake often with interrupted sleep throughout that night. Throughout that week, Mima ate minimally, even with multiple cues to eat. So left food out on the table, asked if wanted something to eat, offered food multiple times, and never really saw her eat really anything the entire time. During the trip, she forgot to order refills on her medication. So of course she was still with it in a sense that she could bathe herself. She knew how to make coffee. She knew where her medications were. She could still walk around unassisted. But a couple of times, you know, she would experience changes based off of what had happened before. So again, she experienced moments of hallucination of other people being in the home that were there over the weekend, but they were no longer there. She even had locked me out of the house. I left one morning to get Starbucks after that straight, 24 hours awake, and I left the door unlocked because she wasn't awake yet. And when I came back, she had locked me out of the house and was frustrated that I had left her door unlocked. So, throughout those days, a couple of different things happened. Well, as we fast forward to early December, she had actually misplaced all of her medication. So there were short periods when none of the daughters lived in the same city as grandma. So when the daughters would transition one in and one out, or there was a time for some reason one day someone couldn't be there, during that time, grandma had misplaced all her medications. And so I brought up with my uncle that I think it's time for hospice. And he said, let me talk to the sisters. They're the decision makers. Let's see what happened. So we get to December 24th and Mima had a fall. She was taken to the ER with a fractured hip. The physician stated that surgery would be the best option. The granddaughter says surgery is not a good idea, as Mima will not remember that she had a fall or that she had the surgery. And there's a 50% mortality rate for dementia patients after a fall within 6 months. From that time, she did have the surgery. She was discharged to a skilled nursing facility for rehab based off of the hospital and physician recommendations. The daughters then were having to stay at a facility 24/7 to prevent a fall. Mima wanted to be at home, and the granddaughter and the son requested a hospice meeting. Now, why did the granddaughter or the daughters have to stay in a skilled nursing facility with Mima to prevent a fall? Well, for those of you that live in Texas, there is a law that states that everyone has the right to fall. So you cannot have any restraints. You cannot have bed rails that can prevent someone from trying to get out of bed if they're capable to do so. So when you're thinking about a person with dementia and their memory is not so much of their short-term memory is not there, right? So to be able to remember that you recently had a fall and you had a surgery and you've transitioned from your home where you're familiar with how to get around, where the bathroom is, where the coffee maker is, where your bed is, to go to a hospital, and then from a hospital to go to a nursing home that you're not familiar with, you are at a huge risk, or that your loved one is at a huge risk for falling, and no one can prevent that from happening. Now, every facility, we are all practicing safe falling. So there's floor mats or there's things that can be put in a room to help have a safer fall, but falls cannot be prevented. And in a nursing home, we think about how many beds or rooms and how much staff is in a nursing home 24/7. There's typically not someone next to your loved one's bed the entire day or entire night, ensuring that they don't get out of bed or reminding them, hey, you can't get out of bed. So the daughters stayed at the nursing facility, got approval for that to stay 24/7 to help prevent a fall. She was there for about 2 weeks and then she wanted to go home, and so they transitioned home. But again, that conversation of discharge planning, which that typically has happened 72 hours after arrival to a skilled stay, you have to figure out what is the plan to go home, right? Typically, when someone has a surgery and they're going to need rehab in order to get back to what their baseline was. So remember, before the fall, she was able to walk, she was able to bathe herself, she was able to make coffee, she was able to do a lot of things for herself. But now with the fall, there's a lot of rehab involved, and you have to practice and work towards gaining strength from that fall. So not based on the fact that Meemaw had dementia, but based on the fact that she had a hip surgery with a fall, that her recommendations were rehab and home health, because we're looking at why she went to the hospital and what are the goals for her to gain back that strength to get to baseline. So her physician recommended home health. So Meemaw was discharged home on home health on January 11th. Meemaw died January 15th at the hospital after coding at home, being resuscitated and intubated. The family agreed that it would be best for her to not live that way. So as I was talking about briefly before, we look at what are the goals of home health. The goal of home health care is to treat an illness or an injury. An example is sepsis, rehabilitation from surgery, or pneumonia. Home health care helps patients get better, regain independence, and become as self-sufficient as possible. Home health is not usually a long-term service. Medicare Part A and or Medicare Part B covers eligible home health services like intermittent skilled nursing care, physical therapy, speech language therapy, and more. What Medicare does not pay for is 24-hour daycare at home, meals delivered to the home, homemaker services, or personal care. Who's eligible for home health? So a patient must be under the care of a doctor and must be getting services under a plan of care established and reviewed regularly by a doctor. The patient must need, and a doctor must certify that they need one or more of these: intermittent skilled nursing care other than a blood draw, physical therapy, speech language pathology, continued occupational therapy service, and the condition must be expected to improve in a reasonable and generally predictable period of time. So we know, based off of what the patient is needing this therapy services for, we know how long they need to do it for in order to improve, right? It's not that it's going to go on forever. There's a specific time period that they're going to receive this therapy, and by that time, the goal should be that they are back to their baseline. The patient is not eligible for the home health benefit if they need more than part-time or intermittent skilled nursing care. So again, these different therapies that are being provided, or this skilled nursing care, again, is for a specific reason. The goal is to get back and for improvement in care, and there is not someone there 24/7. The patient, the therapy staff or the nurse is coming intermittently based on a plan of care, based off of what the service is being needed for. Again, in this case, we look at Meemaw, rehab of the hip. The goal of the rehab of the hip is to be able to get her to be able to walk with assistance, maybe like a walker, or be able to be mobile and gaining strength in that hip. Because of course, if we're not using our hip, if we're not getting up and moving around, then we're not gaining strength in that area to be able to hold our body up, to be able to get around, to be able to do that independently. The patient must be homebound, and a doctor must certify that the patient is homebound, so they cannot leave their house. The patient must be confined to the home related to a medical or a physical condition. The patient may leave the home for medical treatment or short, infrequent absences for non-medical reason, like attending religious services. So if they could go in a wheelchair to church, or they can go in a wheelchair to a doctor's appointment, or maybe even dialysis. but there must be a normal inability to leave the home, or the patient has trouble leaving the home without help, like using a cane, wheelchair, walker, or help from another person because of an illness or an injury. So what is home health? Home health care is a wide range of healthcare services that can be given in the home environment for an illness or an injury. Home health care is more convenient and just as effective as care you get in a hospital or a skilled nursing home. So some examples of skilled home health services include wound care for pressure sores or a surgical wound, to educate, teach, and train patients and the caregivers. For someone needed intravenous or nutrition therapy, IV antibiotics, or someone that may have a tube feeding or IV hydration, someone needing injections, or monitoring a serious illness and an unstable health status. So what services does home health provide? Medicare coverage criteria require that the patient receive at least one qualifying skilled service. A skilled service is defined as a service that requires the skills of a clinician for safe and effective performance. If the average non-medical person without specific training can perform the procedure, then it would not be considered skilled. So we're looking at someone that has a license to provide that type of care. A skilled service may include nursing services, physical therapy, speech therapy, or occupational therapy. So non-skilled would be like a home care, someone helping to cook meals. You don't have to be a nurse in order to give someone medications if you're their caregiver, right? It doesn't, only a licensed person cannot be the only one to give medications, right? We can give medications, we can take medications ourselves. So it's something that a licensed skilled professional has to do. When we look at home health for dementia persons, it can be ideal for patients with mild to moderate dementia. Mild dementia is marked by being able to participate in all 6 activities of daily living, which I'll review here shortly. Moderate dementia is marked by ongoing cognitive decline and some difficulty with 1 to 2 activities of daily living. The activities of daily living are dressing, bathing, eating, transferring, ambulation, and incontinence. So someone with mild dementia is able to do all of those activities of daily living. So they would be a good candidate for home health if they had a fall and were able to do all of these things. But also we want to look at, are there any other underlying conditions when we're looking at the full picture? Again, when you're looking at just one diagnosis or one illness or one injury versus the entire picture, that can play a difference in how someone is able to participate in the therapy. Age is a huge one. So we look at Mimo was 91 years old. 91-year-old versus maybe a 60-year-old or a 70-year-old is going to be completely different in how they handle the therapy, because of course, as we get older, we're starting to spend more time in bed. We're not eating as much. Our strength isn't as high it was as when we were 60 or 70. So age can play a huge factor in that. Again, cognitive decline, it really just depends on, cognition wise, are they able to understand what's going on? Can they recall that they fell? And are they able to participate in the therapy? So now I'm going to transition into the goal of palliative care. The goal of palliative care is helping patients to achieve and maintain maximum physical, emotional, spiritual, vocational, and social potential despite the progression of their terminal illness. Palliative care provides relief from pain and other symptoms. It affirms life and regards dying as a normal process. It neither hastens nor postpones death. It integrates the psychological and spiritual aspects of care, provides support for patient and family, uses a team approach to address needs, will enhance quality of life, and may also positively influence the course of the illness, and is applicable early in the course of the illness in conjunction with other therapies. So you can be on home health and receiving palliative care. We look at what's the difference between palliative care versus curative care. Palliative care is symptom driven. So we're looking at the symptoms that are happening because of the disease. We're looking at comfort and quality of life. The patient is in charge of their care. The disease process is secondary to the person. What is making the person more comfortable versus what is curing the disease? And there's many choices that you have when you're under palliative care. When you're under curative care, it's disease driven. So we know that by doing these things, taking these medications, doing these surgeries, these treatments are going to cure the disease. And that's a goal, curative. That's the main concern. The doctor is in charge and they're making recommendations based off of their teachings, learnings, and their medical degree. The disease process is primary. So even though the person may not feel good based off of the medications they're taking, because sometimes we know that medications have medications can cause symptoms, or a medication may not work for every person because every person is different, but we're looking at what we know can cure the disease. So there's fewer choices because we're looking at what's curing the disease, and that's the pathway that we're going to follow, or the doctor's going to follow. Really, when we look at palliative care, we know that when the patient is experiencing relief from pain, that they're receiving psychological and spiritual care, that they have a support system that assists the patient with being as active as he or she wishes. So they're not hooked up to machines. They're not continually going in and out of doctor's appointments, seeing all these doctors' office, going to all different doctor's offices and specialists. But they're able to do the activities that they want to do, go and visit family, have lunch with friends. If they like doing gardening, being outside, we're looking at what is going to cause the best relief from the symptoms that they're experiencing for them to have the best quality of life, and a support system that sustains the patient's family. So when we're in home health, the home health care and the plan of care is based around the patient and the patient only, and what the patient needs in order to get better. When we start to transition from, even curative again is about the disease. It's not about the patient. It's not about their family, and having that additional support. When we transition to palliative, that's when we start to have a little bit more support for the caregivers, for the family, and for the patient in, this is how we're going to manage the symptoms that are going to arise from this disease that we know we're not going to be able to cure. There's often a lot of misconceptions, and these are just a couple of them in regards to hospice and palliative care. That hospice and palliative care means doing nothing. All treatments are discontinued, so you're not going to have any medications. We're going to stop all your medications. All invasive interventions such as chemotherapy or radiation are stopped. That hospice is only when a patient is dying, and that hospice is a place. Hospice is considered palliative care because palliative is symptom management. So in hospice, we are providing symptom management the same way that palliative care is. But in the regards of palliative care Palliative care can be many different things to many different people. There's not a specific plan of care for palliative care. It could be based off of what your insurance company thinks that palliative care should be. So it could be, you know, a nurse visit once a month, a doctor's visit once a quarter. It could be that they have a social worker that's available as needed, but it's not a real true plan of care that there's people going to be visiting at certain times or periods, right? And so that's when we transition into hospice care. So you could be on palliative, and with palliative, that's one arm. So we're looking at palliative as like a specialist. So palliative care, there's a physician in place or a nurse practitioner that's trained in palliative care that coordinates with your primary care physician or your specialist in regards to symptom management. But you could also be on home health, and you would also have your medical equipment provided by another durable medical equipment company. And then you have your medications ordered by your primary care physician or your specialist, whoever's ordering your medications, right? So with palliative care, you still have all the care providers that you've been having. And if you need medical equipment, you're going to have to call the DME company. If you need medication, you're going to have to visit your primary care physician. It's just an extra layer of physician support with palliative, but it doesn't necessarily mean that you're receiving a full gamut of services and you have someone that can come visit you in the middle of the night or on the weekend. So it's an additional arm. Now that we transition to the Medicare hospice benefit, it was actually passed by Congress in 1982. And there's 4 levels of hospice care. So in the beginning, we talked about home health, and home health has different services based off of plan of care, right? So if your doctor thinks that you only need a nurse to visit 1 or 2 times a week for wound care, then you're only going to have a nurse visit 1 or 2 times a week, and they're only going to go for wound care. If you are having a symptom of exacerbation, shortness of breath, and you have advanced cardiac disease, and I know we're talking about dementia, but you can have them you can have them both. You can have there can be multiple morbidities for your loved ones or even for yourself. Again, the plan of care is going to be based off of the need of that specific patient. So home health, a nurse visit for medication management for advanced cardiac disease, but also we're going to have palliative for symptom relief, and we're going to have our cardiologist, and we're going to have, but for all those visits, you have to go out. The only one that's going to come into the home is a nurse for the medication management. You know, if it's because you had pneumonia, that's what they're going to come for, but not because you have advanced cardiac disease with all these other things going on. They're going because you had pneumonia. And so the goal is to gain your lung strength back from that pneumonia. But when we're talking about hospice, hospice is an all-encompassing service. So we can have routine home care, which is hospice care in the home. It's based off a plan of care, but typically Medicare has requirements for the minimum of number of visits that a hospice should do. So hospice routine home level of care is not 24/7. Hospice routine level of care is a team, an interdisciplinary team that includes a doctor, an RN, a chaplain, a social worker, a home health aide, and an RN team manager that are responsible for the care of the patient at home in coordination with whoever the caregiver is. So is that a wife? Is that a daughter? Is that a son? Is that a nursing home or an assisted living? So it's in collaboration with those people. The visits are based off of the need of the patient, so they could change at any time. Typically, on routine level of home care, an RN visits 1 time a week, a home health aide 2 to 3 times per week to help with activities of daily living. So that can help with bathing, or if we're, feeding, lunchtime, or breakfast time or dinner time, depending on the time of day that they're coming. But again, they're doing visits for a certain period of time with a goal, and then they're going to go on. But in the event that there's a change, or for new hospice patients that are coming on, we can increase the number of visits based on the need of the patient. So if a patient's needing a nurse visit 3 times a week, then a nurse can visit 3 times a week. But aside from that routine level of care and that team coming out to visit, hospice is available 24/7 for someone to come out at 3 a.m., at 11 p.m., on Thanksgiving Day, on Saturday at 4 p.m., because as we all know, emergencies don't typically happen 8 to 5 when everyone is open, right? Typically, emergencies happen after hours and on the weekends. So that's part of the Medicare hospice benefit on routine level of home care, is that you have 24 access to a nurse triaging over the phone, a nurse or a physician visit over FaceTime or televisit, as well as us being able to implement a higher level of care based on the need of that patient at any time. So that transitions me next to continuous care, which is for symptom management. When we're looking at symptom management for both continuous care and inpatient care, we're looking at pain, we're looking at hallucinations, we're looking at nausea, vomiting, diarrhea, things that are very uncomfortable that we've tried giving the typical medications and it's not working. We can implement, hospice implements continuous care, which is in the home, bedside care from 8 to 24 hours a day, dependent upon the need of the patients for symptom management. So daily, Medicare requires that we evaluate that this level of care is needed. It must be provided in increments of 8 to 24 hours a day until the symptom has been handled, right? So then we go back and transition to routine home care. When we're looking at continuous care, the one thing that we have to remember is that we're working with people, right? And it's not a guarantee that when we have those 8 to 24-hour shifts, we're going to try everything in our power to have somebody there, but there could be a possibility that there's a nurse not available, or if the nurse was in a car accident on the way, or that something was to happen, right? So it's never a guaranteed care. The goal is for us to be able to provide that care and to do our best to be able to happen. But again, we are healthcare. Nothing in life is guaranteed. So I like to be upfront with, yes, in a perfect world, we're providing that care around the clock. Nothing happens and it's all great and everyone's going to have sunshine and rainbows. But I like to be realistic. Things can happen. But the hospice team will always communicate with you what's going on and how we're going to help this scenario. And then as we transition to inpatient care, some hospices, not all hospices, have inpatient care. So inpatient care can be provided in a place. So a hospice, it could be called a hospice house. It could be an inpatient unit. It could be a wing in a nursing home. It could be, but it's specific to that hospice providing a higher level of care, where the hospice actually takes over the 24-hour care of your loved one, with nurses providing care 24 hours a day, a doctor rounding daily, the social worker and chaplain there visiting patients in the inpatient units and talking with families. So where typically in the home setting, the loved one or the caregiver, the paid support, is the one providing the main care, and we're coming in as collaboration. On inpatient care, which again is for symptom management, the hospice takes over that care. Or if the hospice is contracted with a nursing home, it might be that a nursing home is taking over that care, but providing that high level of support for symptom management. To get the symptom under control as quickly as possible. Some things that we might do in a higher level of care for, it could be IV medication, IV pain medication. We could do higher levels of oxygen. We could do more around the clock. You know, a patient that's needing a nebulizer treatment very frequently, or needing pain medication more frequently than they were at home, that's something that we would want an RN to be able to take care of and manage, and be able to call the doctor to quickly get symptoms managed and get the patient as comfortable as possible. And then the last level of care is respite care. So respite care is provided in a skilled nursing home contracted with the hospice. So the hospice have a contract with nursing homes, typically close to where the area where you live, where we can send your loved one to that nursing home to give you respite as the caregiver to take care of things that you need to take care of and take care of you. That's part of the Medicare hospice benefit. There's no charge to you. There is not a rule on the number of days that someone can receive continuous care, inpatient care, or respite care. It's based on the need of the patient or how frequently, right? So it's not, you can only stay there for 24 hours, or I can only do it for this long, but it has to be symptom driven for continuous care and inpatient care. Respite care is to provide respite. So one thing that's been happening is, and we still have around, is COVID. So let's say that you as the caregiver get COVID and you don't want your loved one to get COVID, or you need time for some relief for yourself to take care of yourself. We can put your loved one in respite care, in a skilled nursing care, and they'll receive care 24/7 from that nursing home, along with our hospice still going in to visit your loved one, right? We're still in charge of the plan of care, but we can help take care of them in a nursing home. You can still visit them, but please not if you have COVID. You can still visit them and see them, but it's a time for you as the caregiver to take care of yourself. Also, respite care can be used as a transition. So sometimes it's hard work to take care of a loved one with dementia, especially with all of the things that could happen, all the care that can be provided. So I know some of you out there have been married for 54 years and have been married for 40 years. And taking care of your loved one can be very challenging, and it's okay to say that you need help or that you can't keep them at home because it's not safe for you and it's not safe for them, right? We're looking at the safety. We're looking at the type of care that they need. So we often use respite care as an introduction to possible placement. So you get the opportunity to try out a nursing home in your area where the hospice is contracted with. Your loved one starts to get comfortable with visiting that facility and transitioning from respite care to possible placement in that nursing home. So that's one way that we can use it. If you get sick, if you have a surgery planned, if you want to go on vacation to visit your other children, or you want to go on that cruise that you scheduled with your sisters, we can do that with respite care. Sometimes we have caregivers that do respite care every 30 days for 5 days. So again, it's based off the plan of care. It's on the need. We can do 5 days based off the Medicare hospice benefit, but there's no rule in, you can only do it every 30 days, every 60 days, every 90 days. If something happens, we can transition to respite care. So you can talk to your hospice social worker or nurse about that. Hospice covers 100% of costs related to the terminal diagnosis. So hospice is 100% responsible for all the medical equipment. It's delivered and ordered by the hospice company. It could be a third-party DME company, but the hospice is responsible for the ordering, the delivery, and the payment to that DME company. If something breaks, if something happens, if you need more equipment, you call your hospice and your hospice orders whatever it is that you're going to need. We also cover the medications. So like I discussed before with home health or palliative, you still have to call your primary care doctor. You still have to visit your doctors in order to get those medication refills. When it comes to hospice, then that's part of what the nurse is visiting for. We're making sure that the medications are still working to provide a high level of quality care for the patients that we're taking care of. So we are responsible 100% for the cost of medications related to the terminal diagnosis and anything that's attributing to the terminal diagnosis. So we can order the meds. We find the pharmacy, we order the meds, they get delivered to you, or a nurse will bring them, or, depending upon the situation, we can order them at a pharmacy close by. But again, the hospice is responsible for the cost in regards to that medication. There's an unlimited benefit period. So with home health, remember we're talking about it's for a specific time period. We know that it's going to be approved for this many visits for this long based off of that specific illness or injury. Hospice has an unlimited benefit period, but 2 doctors must certify that based on the trajectory of the illness that we believe the patient has 6 months or less. We don't have a crystal ball. We don't know what's going to happen. Oftentimes with patients with amazing caregivers that are really getting your loved ones to eat and providing great care and getting them out of bed and taking them outside for walks, all those things that you don't think about as really helping and providing great care, or that you think of, this is just my day, like these are the things we do. All those are leading to a longer lifespan. They're all keeping your loved ones healthy. And so we can think maybe because of a hospitalization or a fall that based off of experience that patient might have 6 months or less to live if they continue on the trajectory. But sometimes people get better. It's not their time, and we can discharge patients off of hospice, or sometimes people have a slower decline, or they've been referred earlier on. They're getting the best care. They have a great quality of life. They're not getting hospitalized, but they still are on that disease trajectory. People can be on hospice for longer than 6 months. They can be on hospice for longer than a year. But again, it's based off of physicians certifying that we believe, based off our evaluation period of the patient, which we do those evaluation periods frequent basis. So it could be 30, 60, 90 days, depending upon the benefit period that they're in, and that we're certifying that the patient still needs that care. And all of our care hospices can provide nurse visits 7 days a week, 5 days a week, can provide whatever level of care. We're getting paid the same dollar amount no matter how many visits that we're doing, because it's based on a per day basis. So it's dependent upon the need of the patient, but there's no requirement that says you can only do this limited number of visits. It is based off of the need of the patient. And that's in collaboration with you as the family member, the caregiver, and the hospice team. So I talked about what's all covered with hospice: the nursing visits, physician visits. Physicians can come to the home, hospice aid visits, volunteer services. So we can have pets come out to visit, dogs. We can have music therapy, medical social services, spiritual counseling, nutrition counseling, bereavement support for family. When we're looking at social worker, all hospices have social workers. Social workers are not coming in to tell you all the bad stuff and the bad things that you're doing wrong. The social worker is really coming in to help support and identify resources that would benefit for you and your caregiver. They're not here to report anyone to protective services. They're not here to judge. They are really here to identify resources to help guide through the process of even preparing for funeral arrangements, helping to apply for VA benefits, helping to get Medicaid if Medicaid is needed, helping fill out FMLA paperwork. If there's children involved or young children, young grandchildren, talking to them about the loved one in the process that they're in, or also helping make memories. So, getting thumbprints or handprints, helping helping them, write birthday cards or Christmas cards, or doing gifts, or making a memory box, or whatever the case may be. The social worker is there to help with that. It's there to help with the very challenging psychosocial portion of this. For many caregivers, this is a whole new life that you're going to be experiencing once your loved one passes, and it's going to be hard because you've done such a great job. But then you get to this point of, now what do I do? I've been taking care of my loved one for years and years, and this is all I know. How do I get back to taking care of me? That social worker is there to help you as the caregiver. So you get all of these services that are not just for your loved one. Hospice is for the entire family. And so that's what makes it's so all-encompassing and so beneficial for everyone, rather than, you know, who's going to this doctor's appointment or who's going to this visit or who's going to take care of mom. You know, everyone's working together to collaborate on what's best, and everyone is prepared for what's going to happen and having those hard conversations. To this day, you know, my grandmother passed away in January of last year. We all think about her every single day. There was only one daughter with her at the time that she was extubated. No one else was there. And so a lot of the children are still struggling with that grief. And, you know, that was my mom for 60 years, 70 years, for my father and for my aunts. So I know that it can be hard for a lot of you that when it's your parent and this is how you remember them, or you think about the times that they had the bad days. But hospice helps to remember the good days and helps to prepare everyone for what's going to happen, rather than being blindsided about what's next. So is your loved one having trouble communicating or speaking? Spending most of the day in a bed or chair? Confused and or spending more time sleeping? Unable to walk, get dressed, or bathe without maximum assistance? Incontinent of bowel and bladder? Having difficulty swallowing or refusing to eat? Moving to an assisted living, memory care, or personal care home? Or in the last 6 months, have they visited the emergency room or been hospitalized or lost weight unintentionally? If you answered yes to any of those questions, it might be time for hospice. Your loved one may be eligible to receive hospice services. I know that I've really, I've talked about each one of these individually, but this is just a good little check box for what is the difference between VITAS versus palliative versus home health based off of the eligibility requirements. So again, hospice, 6 months or less. Palliative care, it varies by program, but usually it's a life-defining illness. And then for home health, a prognosis is not required. But a skilled need is required for home health. A skilled need isn't required for hospice or palliative care. With palliative care and hospice, we have quality of life and defined goals. Home health is restorative. The length of care is unlimited on hospice, and you do not have to be homebound. You can leave your house and be on hospice. You can live life and be on hospice. We urge and encourage that. If you want to go gambling, if you want to go to the beach, if you want to go fishing, if you want to visit a loved one in another state, you can do that on hospice. Medications are included, equipment's included, after-hour staff. We can do therapy, respiratory therapy, physical therapy, occupational therapy, and speech therapy on hospice. The only difference is that we are not going to restore back to baseline. We are going to look at what provides the best quality of life. So if your loved one had surgery or had a fall and we're going to do physical therapy or occupational therapy, the goal would be what is your loved one's goal, right? Do they want to be able to get out of bed? Do they want to be able to go and sit in the front porch? Do they want to be able to go to the living room and not be in bed all day long? Do they want to still go out places? How can we help them gain the strength to be able to help their caregiver get out of bed to transition to a wheelchair? Or to be able to gain the strength to use a walker, maybe if it's a fall but without a fracture, right? So we want to do this to gain strength, to have the best quality of life. For hospice, nurse visits are unlimited. For home health, it's limited based on the diagnosis. With levels of care, hospice, we have 4 levels of care. Palliative care is only 1 level of care. Home health is only 1 level of care, the visit required. And then, of course, we offer bereavement support. So once your loved one passes, then we provide bereavement support 13 months past the death, because we want to be there for that 1 year memorial of the death, as well as after that. But hospice is always available for bereavement support or support groups, grief support, caregiver support group. And those are not, again, we're looking at the entire family and the needs of not just the patient, versus palliative care and home health. We're looking more at either the goal of the diagnosis or the need of that specific diagnosis for symptom management. I do this in memory of my Mima, Edna, who just would have she celebrated her heavenly birthday last week, on the 30th of July. And so I hope that this is beneficial to all of you guys, and sharing this real true life experience that I enjoy speaking so much about, but also that I just am so passionate about helping all of you, because there's plenty of books on how to raise children and plenty of people to tell you how to raise a kid and give you ideas. But when it comes to caregiving, every person's journey is different. Every person's family dynamics are different. So there are so many different aspects of taking care of someone that is getting older, and is from a different path of life, or has multiple morbidities, or able to walk versus not able to walk. So there's just so many challenges to being a caregiver, or to being a medical provider that helps caregivers or takes care of patients as well. So thank you all for all that you do, and know that I'm always here to support you guys the best that I can, and BTOS is here to support you with any of your questions as well. But I'll transition now to questions if anyone has any questions for me.
Candace, let me first say this is like the best primer on the differences that I've ever heard. And your slideshow is going to be there for everybody. So it's fabulous. Thank you so much. Really appreciate that. Okay, folks, you can put your hand up. You can unmute yourself. If you're on the phone, you can press *6. And I can see that you've done that on my little website here. And Yarlin, did you unmute yourself? No?
Hello, this is Gina.
Hello. Yes, we can hear you.
Oh, good. So I have a question. And I'm sorry if you covered this. I had some transmission problems. My mom is very far along, basically towards the severe dementia, I would imagine. She's completely, can't feed herself, hardly speaks, is completely wheelchair bound. Doesn't walk. She also has Parkinson's, in combination. We feel she's towards the end. However, her organs and everything are healthy. How do you know whether you start with palliative care or hospice care? Because they seem to have a very vague overlapping.
Yes. So palliative care, hospice is palliative care. Hospice provides symptom management. So that's what palliative care is. The only difference is, are we still going for aggressive curative care? So we want to think about, in the event that your mom was needing to be hospitalized, would she want to go to the hospital, and would you want her to go to the hospital and for them to do everything to keep her alive?
Yeah, this is something we're struggling with as a family. Of course, my dad is very much in the picture and very cognizant, and he's 91, and he's struggling with those decisions, and we're trying to nail that down in the next couple of weeks.
So that would be that's my main question. In the event that something happened today or tomorrow, would she, and that's why I urge everyone to have advanced care planning and goals of care conversations prior to getting to this point with your loved one, because it's, or even for you, it's your decision and you have to let your decisions be known. What would she have wanted? And what will the outcome be? If she were to be hospitalized, would would they have to intubate her? Would she have to be on life support? And when she got out of the hospitalization, what would her quality of life look like? So those are things to think about. And just because we're choosing hospice doesn't mean we're hastening death, that we're making it faster. Doesn't mean we're going to give a magic pill and she's going to be gone tomorrow. But in the event that something came up where she did have a symptom, hospice would be able to support that symptom to prevent the hospitalization and make it as comfortable as possible. Or even, something that's very, that happens pretty frequently, we all know with dementia, is urinary tract infections. Hospice treats urinary tract infections. You're going to have symptoms from urinary tract infections, and part of having the urinary tract infection is because of the disease process. So we do treat urinary tract infections on hospice because urinary tract infections are not comfortable. So those types of things, when we look at the trajectory of the disease, what is best? Are we doing symptom management, or are we wanting to keep her alive as long as possible? We can still want to keep her alive as long as possible in hospice, but do we want the poking and prodding and the breathing machines and the aggressive treatments, and how would her body be able to handle those things? But one thing I always suggest is you can get a hospice information session only. So people like me and like my organization, we can come out and we can just do a family meeting, or we can do a goals of care conversation and really just talk through it. What does hospice provide? Can evaluate and see what we would specifically provide to your mom for your dad to be comfortable asking the questions. The kids can all be there. Typically we can do hospice information sessions in the evenings, on the weekend. So hospice, we do not work 8 to 5. We work 24/7, 365. So I always say you can never talk about hospice too early, but you can definitely talk about it too late.
Okay. That's really helpful
Thank
information.
you. Thank you, Yarlin. It was a great question. And Gina, you're next, and then I've got Maxine following you.
No, that was my question. So thank you very much. That was really, really helpful.
Awesome.
Yes, it was very clarifying. Thank you so much, both of you. Maxine, what do you have?
My husband also has Parkinson's and moderate dementia. And my question is whether during hospice care, the carbidopa, levodopa medication that most Parkinson's people take to control the on and off symptoms would be administered. Now, to me, that is definitely a comfort tool. Without that, I have symptoms, something like withdrawal, I suppose, and are really miserable. I go along with, stopping vitamins and statin drugs and thyroid, all that stuff. But to me, the Parkinson's meds would be a comfort issue. What's your thought on that?
So I'm not a clinical, I'm not a physician. Ultimately, it would be the hospice physician that would decide what medications we'd be allowed to continue. So what I suggest is getting that hospice information session. When VITAS goes, we typically send an RN, and the RN evaluates all the medications, and we'll call the doctor from that appointment to see if the doctor would approve, or the doctor is the one that makes that decision along with the family. So I don't want to speak out of turn and say yes or no, because I'm not a clinical person, so I apologize for that. But I recommend, if you're interested in hospice, bringing that forward, because again, it's a collaboration of care between both. And in the event that if it's a name brand drug, what I've seen just from experience is there may be like an alternative that hospice provides. So it could do the same exact thing, but it may not be a name brand. It may be
That is,
comparable.
it is generic. That is not a
Okay.
brand. Yeah.
Yeah, then
Okay. Well, thank you.
so
That certainly answers my question. Thank you so much.
you're welcome.
Yes, and I'm sorry, we've kind of reached the end of our time here, but I have a couple things I wanted to talk about. first of all, just to say, as many people have just put in the chat room, what a beautifully clear presentation this was. Thank you so much, Candace. And if you are registered, you will get her slides. And the great thing about that is you will then have a primer for the difference between these different kinds of care. And you can look it up and go back to it, print it out. So if you're not registered, you won't get that. So in order to register, if you got this from somebody else, you know, the number or the Zoom, call WellMed Charitable Foundation's customer service person, 866-390-6491. That's 866-390-6491. And the great part is, once you register, you'll also get the monthly calendar. And we do have a couple more presentations that look very interesting this month. So you'll be able to see those in addition to the ones in the upcoming months. We so appreciate what every caregiver does and understands how hard, how difficult it is, how easy it is to get burned out and to feel like you're alone in the world. But you're not alone. You know, there's people there like Candace and so many others who care about caregivers. And so we hope that you will take advantage of that. I'd like to thank also the WellMed Charitable Foundation for all that they do to help caregivers. That's what they're all about. They run the SOS centers, Stress Busters, trainings. They have clinics in Texas and in Florida. And they're just, you know, they schedule all of these experts to come and work with the participants to really try to educate us, to try to get us to help make decisions that are good for us as well as our loved ones. So with that, I am going to stop the recording. I want to thank you all so much for being with us today. And I hope that you all have a great day. And without COVID, be careful. And that you will come back and see us again soon. Thank you, Candace. You were great.
Thank you.